Hello and welcome again to a special program from Community Health Media. Today we're going to be targeting something very special. We're going to be targeting the evolving field of metastatic HER2-positive breast cancer, exciting data that we need to disseminate and digest with you to better serve our patient. I'm going to be the moderator for today. I'm Jason Mouabbi, and I'm joined today by two of my esteemed colleagues, Dr. Yan.
Hey, my name is Fengting. I'm from Fred Hutch Cancer Center in Seattle.
And I'm joined by my best friend, Paolo Tarantino.
Hi, I'm Paolo Tarantino from Dana-Farber Cancer Institute. So happy to join you for this program.
Yes, I'm so excited to be here. Let's get down into it. I'm going to start with you, Paolo, first to set the field for us. Why is it so important that finally ADCs are moving to the first line setting in metastatic HER2-positive breast cancer?
So I think at least for two important reasons. The first reason is that up to now, we've been having a first-line treatment, the CLEOPATRA regimen with taxanes, which has clear cumulative toxicities, neuropathy. And so in the CLEOPATRA trial, patients were not mandated to receive a certain number of cycles, but just couldn't get more than a certain number because of neuropathy, because they couldn't touch anymore, they had tingling. And ADCs instead, especially topo 1 ADCs, do not have this issue. And so there is an opportunity to give the treatment for longer, and this way, ideally, hopefully, to lead to better long-term outcomes. And we know that in HER2-positive disease, this means potentially curing some patients. And so really, the opportunity to use the best agent you have for a longer time really leads to this hope of curing more patients with breast cancer. And then the second big reason, that is attrition. We know that there are some patients that never make it to the second line or never make it to the third line, usually because of aggressive progressions of disease, sometimes brain progression of disease that require radiation or just lead to worsening general conditions and no more treatment. And so we really don't want our patients to lose the opportunity to get the best treatment for their disease. And so this is why, after seeing DESTINY-Breast01, outstanding data with T-DXd in highly pretreated patients, and then DESTINY-Breast03, outstanding data and improvement in overall survival in the second line, I think it totally makes sense to take T-DXd with or without pertuzumab to the first line.
And since I have you here, Paolo was the one, and we were early in our career at that time when the DESTINY-Breast03 was presented and the separation of the curve. He put a tweet, he was like, what can we fit between those two curves? Remember that day? Some people said the Eiffel Tower, some people started putting all those kind of stuff. It was fascinating though, because we never seen a separation that big.
And that started a tradition of driving a truck.
Yeah.
Whenever you can drive a truck and you can put a truck between the lines, the Kaplan-Meier curves, it means it's a really, really, really meaningful advancement. And DB03 definitely was, and DB09 definitely is.
So DB09, you mentioned that, Dr. Fengting. So DB09 is trying to challenge the decade-plus-old CLEOPATRA regimen. Can you please walk us through the study design of the DESTINY-Breast09?
Yeah, absolutely. DB09 was a groundbreaking phase 3 randomized international clinical trial that randomized the newly diagnosed or recurrent HER2-positive disease in the first-line setting. So they were randomized 1:1:1 to either T-DXd alone or T-DXd plus pertuzumab, or the decade tradition TXP followed by maintenance therapy. And over 1,000 patients were randomized. And right now we only have the data from the two groups. So we're looking at T-DXd plus pertuzumab and the traditional THP followed by maintenance therapy. And follow that conversation. When I was a fellow, when I was told if you can put a fist between the two curves, we were celebrating.
I think they've all.
Now we are getting trucks.
That's so true. Yeah. And something that you mentioned, the CLEOPATRA is an induction maintenance, although the CLEOPATRA essentially when it was designed, it was never designed to be an induction maintenance, but they had to. Patient could not tolerate more than 8 cycles, a lot of them 6 cycles, right? And that's why they say 6 to 8 cycles induction followed by maintenance HP, whereas the arm that we all have right now is the T-DXd pertuzumab, is continuous treatment until unacceptable toxicity or progressive disease. So definitely a fascinating study. Paolo, can you walk us through the results of that study?
So yeah, for the moment, we have part of the results because the T-DXd alone arm is still blinded. And I do hope that we'll see the results soon, but we do have the results from T-DXd pertuzumab versus THP. The results were presented last year and published on New England Journal of Medicine, and they showed that with the CLEOPATRA regimen, in modern times, where we also use endocrine therapy in the maintenance setting, you achieve approximately 27 months PFS, which is not bad. It's about 2 years. But with the T-DXd pertuzumab arm, with this more prolonged administration of cytotoxic treatment, that median PFS reached up to 40 months, 40, which is really outstanding. It's almost 4 years. It's just really meaningful. And also in terms of response rate, not too different, but complete response rate was more than double with T-DXd pertuzumab, up to 15%. And now we've been seeing more data showing that actually the partial responses observed, which are approximately 70%, include about half are deep partial response, over 80% approaching a complete response. And so I think we're seeing these deep responses that we know, and we're seeing also in the updates of DB09 that lead to prolonged responses. Over 80% of these are ongoing at 2 years, and hence the idea, could some of these be never-ending responses?
Yeah.
Could some of these be permanent responses? We're not yet there.
Yeah.
We need more follow-up, but I think it's so promising to see that.
Dr. Fengting, let's dissect those efficacy data, mainly PFS that we have. You know, at 6 months, the separation is starting to happen.
Yep.
Right? Definitely the bulk of the response happened after those 6 months.
Yep.
What do you tell the community oncologist that loves the idea of an induction followed by maintenance? They love it. It's been embedded in them. A lot of doctors, that's the only thing they know because they came into after the CLEOPATRA era and they're not accustomed to first line just giving treatment until further notice. They love their maintenance. What do you tell them? Is 6 months enough to give induction T-DXd and then go to a maintenance?
I actually was in that club back in December 2025 too. When DB09 was first reported, you know, my hope was, well, maybe I can give T-DXd plus pertuzumab X number of cycles and I can put my patients on maintenance regimen. I was in that club too, but you know, with the data just reported, it's very clear that the longer the patients stay on the T-DXd, the deeper and more response we are seeing. So I gradually switched my mind, not my fault, you know, with the evolving data. You know, I was just telling someone that, you know, I put one of my patients on T-DXd and pertuzumab December 18th, 2025, right after the FDA approval. When I gave her the first consultation, I told her maybe 6-8 cycles, but right now I'm telling her, you know, if we really want a deep, complete response, and, you know, we got to be on it as long as possible.
Yes.
And the real rationale was that truly, you know, even nowadays, even with MRD, and we truly don't know if the patient truly is having complete response. And I think that's my speculation behind that. So what I talk to my community partners is that, you know, I tell them that if you look at the data and, you know, exactly, we stated earlier, the reason we gave 6 cycles of THP, not because of the efficacy, it is because of the side effects. That's one. Two, we don't know if there is still residual cancer. And also the data prove that the longer the patients stay on it, the more deeper response we see. So literally, I think we should continue the treatment as long as the patient can tolerate.
Yeah. So, Paolo, I want to go back to that because fresh off the press at ASCO, they presented the outcome based on responders. Now, per RECIST, we are always accustomed to complete response, partial response, stable disease. But they introduced a new category that we're not accustomed to called the deep partial response, and they defined it as more than 80% reduction, which is for me, in my mind, is close to a CR, right?
Yep.
And they clearly showed patients, about 50+% of the patient will belong to those CR and deep partial responders.
Right.
Which is very exciting to see because yes, we say 15% complete responders, but the picture is incomplete here because there is a lot of deep responses here. And they clearly showed those patients with deep responses. Some of them takes longer time to achieve them. In fact, they did show it takes, to capture 80% of the patient that reach maximum response, it takes up to 24 months of treatment. Back to the same question I asked Fengting. What do you think is the optimal time if somebody is thinking about the maintenance? When is the time that's maybe okay to do?
So I really wish I could tell you a magical number of months. The truth is that nobody has that number for one simple reason, that each patient is different. Each patient age and goals and disease, size of disease are different. And so I do think we are in an era where we don't have a one-size-fits-all approach of 6 to 8 cycles and then maintenance. We're in an era where we can tailor things based on the clinical setting. And so, for instance, for a patient with brain metastasis, I would definitely prolong as much as possible the first-line treatment with T-DXd. For a patient with recurrent disease, where it's clear that the disease is nasty, is progressing to chemo, HER2 blockade, I would definitely prolong it. For a patient with visual disease, for a patient that is young and motivated and really wants to do everything that is possible to prolong their life, I do think continuing T-DXd pertuzumab totally makes sense. On the other side, you have patients with bone-only disease, patients with de novo disease, patients that have less, more indolent disease, and patients instead that may be more frail, and there you may want to shorten the time, and then the decision can be dynamic, because the patient at the beginning may tolerate well, but after a while there may be some willingness of the patient to de-escalate, and at that point one can think of dose reducing before stopping, and then eventually stopping. And so I do think eventually each patient will have a different duration, and that duration will be really personalized. It will be shared decision making. So I love your story, because basically you're talking to the patient, showing the evolving data, and deciding together when to stop. The good news is that we have wonderful maintenance regimens. They were not studied after T-DXd pertuzumab. It will take a while before we have data with them after T-DXd pertuzumab. But I do think this will depend on the patient, and there definitely are some patients for which you may really want to go beyond 1 year and try to shrink the disease as much as possible, try to get to that sacred graal of the cure of metastatic HER2 positive disease.
I mean, for me, even before I got the responder data, which was very reaffirming of what I thought, if you look at the PFS curves, after 24 months, you see they become parallel. There is a tail to both curves. It feels like after 24 months, that's when patients are getting this kind of maximum response, which were justified by the data presented at ASCO, again, fresh off the press, that truly showed that you're capturing the maximum response in 80% of the patient by this 24 months mark. So for me, I think about it, if you will, maybe it's a longer induction, right? Instead of a shorter induction. What do you think, Dr. Fengting?
Yeah, I do like the fact that the curve do plateaued after 24 months. And a couple of months ago, and actually I had an argument with someone who were advocating for long-term T-DXd. I was like, oh yeah, look at the curve. It plateaued at 24 months. But I do agree that nowadays it's no longer we give everybody X number or X months of induction therapy, and we are over that era, and then we should individualize our therapy. But I do agree that if it's indolent disease, and if the patient had deep or even complete response, and after 2 years, when they had bad quality of life, cannot go back to work, fatigue, alopecia, and I would initiate a conversation with the confidence that if we discontinue the therapy because of toxicity, quality of life, and I'm comfortable to re-challenge them later, well, hopefully we will have even newer agent.
Paolo, I want to get to you. There is 2 subgroup of patients that the study was stratified for, and we keep getting this question a lot. Why is it important to look at those subgroup? One of them are the de novo versus recurrent. Number 2 are the patients that are purely HER2 positive versus those that are triple positive or hormone positive. Why is it important to always look at outcomes in those different populations?
Well, first of all, de novo and recurrence are very different diseases prognosis-wise. We know that recurrent disease is a disease that already showed that it can progress, recur despite chemotherapy and trastuzumab. It's a nasty disease, and it's almost like a second line already in some form. De novo is different. De novo is a purely sensitive disease. The wide majority of patients have outstanding responses, and we know prognostic-wise that de novo do better. Now, the thing is that these subgroups were looked at in subgroup analysis of DB09, and both subgroups derive benefit with T-DXd pertuzumab. Same for ER positive and ER negative. These are very different diseases. We know that about half of all triple positive breast cancers are luminal A or luminal B. They're not HER2 enriched. The HER2 amplification is kind of an additional driver upon the estrogen receptor, whereas ER negative, most of them are HER2 enriched, purely driven by the amplification of BB2. That said, both subgroups derive benefit from T-DXd pertuzumab in DB09. So I think it's important to appreciate the heterogeneity of these diseases biologically and prognostically, because it does enrich the conversation about if to continue, if to stop, what to do basically. But it's important to realize also that these are prognostic features. These are not predictive features.
Yes.
They will not tell you which patient should receive which type of treatment. They do tell you what treatments are available, because we know, for instance, in the maintenance setting, palbociclib was only tested in ER-positive disease. Tucatinib in HER2 CLEOPATRA showed most benefit in ER-negative disease. So we're starting finally to dissect the way we treat these two diseases as it should be, I think.
Yes, for sure. Another, Dr. Fengting, another subgroup of patients that for me is the most interesting, and I'm going to mention why briefly, are the PIK3CA mutated patients. And that's very interesting for me because my first study I did at Baylor under the guidance of Dr. Mouabbi is we looked in the neoadjuvant setting in HER2-positive disease. We were trying to form this algorithm that can predict pass-CR or lack of pass-CR. And the number one thing is if you have a PIK3CA mutation, there was a zero chance, absolute zero, at achieving pass-CR with the old way, like TCHP induction, not the new induction now we have in neoadjuvant. But for me, that was fascinating because then you go and look at the CLEOPATRA study. There was another publication in JCO a year later by Dr. Baselga that showed that THP doesn't do well in PIK3CA, yet PIK3CA is about 30% of the population. What did T-DXd do, plus pertuzumab, do in this PIK3CA mutant population?
Yeah, it was interesting for me to see that, traditionally, of course, we try to use PIK3 targeted therapy in HER2-positive studies. I wish we have better data. And it's an interesting mutation in DB09. It was about 30% of the population too. That is a very unique population, and the data in DB09 was reassuring, and it was interesting for me to see.
Yeah, so it showed like doubling, right?
Yep.
Like if you look at the PIK3CA mutant, it doubled their progression-free survival, and they looked almost like the one that are wild type, it's fascinating to see. And like you said, it's not of us lack of trying to target PIK3CA, it's that so far nothing worked.
Yep.
So it's really reassuring to see that you can use an antibody-drug conjugate and overcome that mutation altogether. So my follow-up question to you for that, isn't that a strong argument? Because we're not checking those 30%, which is relevant. 30% is 1 in 3 patients.
Yep.
Because we're not checking, isn't that one of the strong arguments why people should always go with T-DXd pertuzumab?
Yeah, I totally agree that, think about that 30% that, they have aggressive disease and THP doesn't even work as well. But in HER2-positive mBC patients, I teach them, I don't even need to know because it will not change my mind in the past. But now looking at the data, I think it makes a lot of sense, and especially for that 30%, I think it makes a lot of sense. Truly, that's my argument that I agree that we need to give the most effective treatment up front, especially if I had known a patient already have the PIK3CA mutation, that make a stronger argument. But I have not figured out the mechanism and why and how. I have not figured that out.
Yeah. Paul, I want to get to you. Before talking about the specific adverse event we expect from those drugs, something very interesting when you look at the discontinuations because of a treatment-related adverse events. Some people in the community, some physicians in the community still think that THP is a lighter regimen compared to T-DXd pertuzumab. That's why they feel conflicted which one they're going to use. They talk if more frail or patient with bone-only disease or stuff like that. I want to give them the easier regimen in their mind, THP. Yet when you look at the discontinuation, which for me is one of the best metric about tolerability of a drug, discontinuation because of adverse event, it was 20% on the T-DXd pertuzumab, so 1 in 5 patients. It was closer to 30% on the THP arm. And here the T, you're only doing it for 6 months. You're not doing it until further notice. It was 1 in 3 patients in those. What do you have to say to that? And how can we guide our community oncologists with that?
Well, first of all, putting the words docetaxel and light in the same sentence sounds like a nonsense to me.
It's already a non-starter.
Docetaxel is such a tough drug. I do feel at least the Peru's trial that showed that we could use paclitaxel instead is something that helped, and still there's a lot of use of docetaxel around for this disease. still Taxol does have its side effects. And the main one is neuropathy, more than docetaxel. And neuropathy can be permanent. These patients, we're talking about curing them or at least giving them a prolonged life, leaving them with permanent neuropathy is not great. And many of the discontinuations were related to that. And then there's, of course, hypersensitivity reactions, which are not common but do occur. And there's a bunch of other side effects, neutropenia, which does occur. I do feel that none of these regimens are free from side effects, but taxanes surely aren't. And I do believe that at least we have found some strategies to mitigate them, compression of the hands to reduce neuropathy, scalp cooling for the hair, but still, we do see patients that need to discontinue because of side effects. And with T-DXd, at least we don't have the cumulative side effects, that there is no neuropathy. Of course, there can be still some alopecia, but it's not, in the absence of scalp cooling, is not among all patients. It's less than 50% of patients that will have that. And of course, there's ILD. And so I think that's important to remember that most of the discontinuations of T-DXd are related to asymptomatic or mild ILD. And it's protocol mandated because all patients with grade 2 or higher ILD need to permanently discontinue, or even with prolonged grade 1 ILD need to discontinue asymptomatic. And so it's important to remember even the discontinuations with T-DXd are not necessarily related to intolerance, but because of ILD, which is not particularly common, but still about 10 to 12% of patients may experience that. And so I realize we're going to talk about side effects, but just don't forget to do the CT scans. I had to do it, sorry.
100%.
Yeah, but I do think that a lot of people, when they were referring as a ladder regimen, in their head, they were thinking the maintenance part, not the induction part.
Yes.
And we all do better when we have it in time.
Yeah.
You know, we have this go and 18 weeks, miserable. Later on, we forgot about it.
Yeah.
And I think that's how the mindset was going.
No,
Which makes sense,
Yes.
which is understandable, of course, and which is why we still think about maintenance.
Yes.
Yep.
And I do think even DB09, although it was not designed like that, was kind of an induction maintenance trial because patients were on T-DXd pertuzumab for a median of about 20 months, although this will be updated in the future, and at a PFS of 40 months. So I think, once again, personalization of the duration, I think will be key.
Yeah.
Yep.
Fengting, back to you. It's something Paolo mentioned earlier, that attrition rate is something we think about. We can look at the attrition rate on that study because they did show us how many patients were captured to receive a second-line treatment after. You can clearly see that in the arm with T-DXd pertuzumab, only about a third of the patient received a line after, which for me was shocking. But the THP didn't do that better. Only 50% of the patients that went on THP were captured to receive a second-line therapy. 50% were not reported to receive anything after. Doesn't that also bode to this notion, like I hear it a lot, I want to keep the best agent in my back pocket to give it if patient. What does this data tell you about this notion of keeping this best treatment for the second line?
No, I had to teach everybody, including my patient and myself, over and over, that we are in this era that we have a newer agent, we have new data coming out all the time, and I'm not afraid of I don't have options in my back pocket. This is how I have to teach all my patients all the time. We have to use the most effective agent up front because we are losing about 30% of the time each time when they progress. I'm punished so many times that my patient got liver failure, brain mets, and a lot of other organ failure to the point I can no longer give them any options. And that's when I regret, that's when I feel really bad about doing to my patients. So truly, you know, if a physician is punished enough, that we all know that if we want to keep our patient alive, that we got to give them the effective regimen up front. I like the PFS of almost 4 years that now when I do a consultation, I tell them, you know, I'm confident that most likely I can keep you alive at least for 5 years. In the past, it was 2 years.
Which is crazy to talk about in the metastatic setting.
Exactly.
That's fascinating to have.
Yeah.
Paolo, back to you. So now let's dig deeper into those side effects. And I want to start with the serious adverse events. I want to start with those two things with you, the ILD and the ejection fraction reduction. What can you tell us about the rate of ILD observed and the high-grade ILDs, and what should be done as a practical guidelines in the community to screen for it before it happens?
So yeah, I would feel it was not a surprise to see some interstitial lung disease because every trial of T-DXd since the first DB01 trial showed some degree of ILD. Although I do feel that we got better at detecting it, at treating it. And so you see clearly from DESTINY-Breast01 to DESTINY-Breast03 to DESTINY-Breast09, kind of a stable degree of ILD, but the grades got much lower. The grade 5 got much lower. And so right now, we still see less than 1% of fatal ILD, but in truth, most agents do have some potentially fatal adverse events in rare cases, and it's kind of the counterbalance of a benefit for many patients. And so I do think what we can do, we have about 12% risk of ILD, less than 1% of grade 5. The best we can do is to monitor carefully to catch it as soon as possible and use steroids. And so what is done in clinical trials, doing CT scans of the chest every 6 weeks during treatment, that is not always feasible in clinical practice. And so in truth, most guidelines recommend every 6 to 12 weeks. There is this window that you can kind of manage. For an average patient, you can think of doing every 9 weeks and then later on moving to 12. For a high-risk patient, you may want to do 6 weeks. And so I think we can work in this window. Whenever ILD is caught, if it's asymptomatic, only radiologically detected, given steroids, but you can restart treatment if it resolves. And currently, guidelines recommend instead to permanently stop T-DXd if there is an asymptomatic, a grade 2 or higher ILD. We still don't know if this is needed. This was kind of a precaution made because there were some fatal cases. I do think at some point we'll move beyond that. We'll find safer ways to restart T-DXd, but for now, the basically black or white rule is if they have grade 1 symptomatic, use steroids, potentially rechallenge if it resolves. If they have grade 2 symptomatic, cough, shortness of breath, chest pain, stop permanently, give steroids.
And that's
steroids
in the label.
Mainstay.
That is in the label. So yes, the label
Exactly.
says.
Whereas I would say that cardiotoxicity doesn't seem to be worse with T-DXd compared to TDM1, compared to trastuzumab. It's really related to the anti-HER2 antibody. And we know that it's a mostly fully reversible cardiotoxicity. So critical to monitor for it, to do echoes every 3 to 4 months during treatment for patients. But it's not as scary as anthracyclines, for instance, so I don't feel as concerned about that.
Yeah.
Can I challenge both of you on a
Please.
question? What if those grade 1.5 pneumonitis patients, we have those patients come to us all the time. I had a hard time to call them grade 2, but I'm hesitant to call them grade 1. We call them 1.5.
And these are the one Hoprugo in her study that she
Yeah.
showed us. These are the one that were rechallenged, but they were 19 patients. Here they rechallenged and they did pretty well. A 19 patient study, I'm not comfortable adopting yet in my practice, to be honest, because ILD can be devastating, right? So that's not something that I can play with. What do you think, Paolo?
Well, I do think there's a situation where I do consider challenges when it's not clear what caused that little cough. There is viruses going around. There's many conditions. There's many things. Even just reflux can cause cough, and so sometimes it's really not clear. You have just a few tiny spots on the CT chest, and you ask the radiologist, and the radiologist tells you this will never lead to symptoms. It's impossible. And so in those cases where it's extremely mild, both radiology-wise, symptoms-wise, I'm tempted to do that, so I cannot lie. And so, of course, we have guidelines for a reason, to guide us in most cases, but most cases are never all cases. And so I think in oncology, we always need a little wiggle room for those cases that are outside of the guidelines, that are unclear, and that's the moment where we are doctors.
And you know who can help you with this? Make sure you are on Christmas or any holiday, take a gift to your favorite pulmonologist.
Exactly.
Yes.
So you can send them to your pulmonologist.
Exactly.
Yeah.
And so you can have somebody to talk to can help you triage this and help guide you. Is this likely pneumonitis that's drug-induced, or is likely something else?
Also radiologist.
And the radiologist. For sure. Fengting, I want to go to you. So we always care a lot and we talk a lot about those serious adverse events. However, these are not the common adverse events. 3 more common adverse events that we have to face much more in the clinic and patients care about a lot, especially in that first line, is this nausea, the fatigue, and the risk for alopecia.
Yeah.
What can you tell us about those 3 and what can we do about them?
Yeah, so those are actually the most common reasons for me to reduce the dose. And previously, I am known to be very stubborn. I prefer not to reduce the dose unless I absolutely have to. And I was very hesitant to reduce the dose for fatigue, for nausea. But for nausea, we got so much better schedule steroid and olanzapine, and give them 3 agents prior to the infusion. I have been able to get away in most of the patients when it comes to nausea. So fatigue and alopecia, they are hard. And especially, it's a young patients that they're not ready to lose their hair. And I do counsel them, 90% of the chance you're fine. And also cooling head doesn't even help that much, and we don't have good data.
That's our study.
One study, really a small one, but it didn't seem to help.
Yeah, because of the half-life, and I did have multiple patients very disappointed when they lost their hair. So it's unlike THP. They know the hair will grow up later, and we're talking about at least 2 years of the therapy, and it's hard, but typically what I reassured them is, first of all, grade 2 is about 10% when you look at the data, and also gradually the longer they stay on it, and it may or may not grow back. And fatigue is hard. Fatigue is hard. I do my best to make sure I look into all the other causes, but that's actually often the time when I reduce the dose. But I'm reassured that if you look at in the study, quite some patients had dose reduction, and we were able to keep the PFS. So I do reduce the dose, and it's interesting. Unlike THP, we know how to reduce the dose. Neuropathy, neutropenia, and those are the typical oncology reason to reduce the dose. But for T-DXd, it's actually more because of fatigue and other.
I mean, what's reassuring for me, if you look at the data, about 50% reduce the dose on the T-DXd pertuzumab, yet you see this 40 months PFS. That's very reassuring.
Exactly.
That's very reassuring that the dose reduction, still you can expect that, because 50% of the patient did it on that study. Paolo, back to you. The nausea question, something was a game changer that we start doing, and you talked about it in multiple platforms, is the use of olanzapine. Can you please help our community oncologists? When is olanzapine deployed? How to give it? And should we worry that it is an antipsychotic?
100%. I think it was transformative, and actually it's the only one that has randomized data available from Japan. I believe it was the ERICA study showing that it actually reduced significantly the rates of nausea. And it's a great drug. It's usually given during the evening, just because it can have a slight sedating effect, usually at 2.5 milligrams, and it can be also increased to 5, but usually 2.5 is enough. And it's really transformative. And so I think by including high emetogenic prophylaxis with 3 drugs, including NK1 antagonists, and adding olanzapine for those patients that require, plus of course PRN drugs such as compazine or Zofran, I think for most patients we can really get rid of the nausea, for sure of the bad nausea. Sometimes there's lingering nausea. Those are the cases where you may consider dose reducing, unless it resolves very rapidly. I think it's very individualized, but olanzapine, I think, really was a game changer in this setting, and I think there's no reason to be scared of the mechanism of action, because it does what we need. It makes patients live better.
And it's a very low dose. I always tell a patient that read about it, they read it's antipsychotic, I tell them the dose we use for the nausea, it's a very minimum dose. It's 2.5 milligram. The dose they use for antipsychotic is 10 milligram.
Right.
So it's 4 times the dose that we use. So they get very relieved. And some patients even give them half the dose of 2.5. They still do pretty well. Now, getting back to you, Fengting. So, I mean, it's definitely revolutionary, this treatment, side effects. We can manage them. We can follow them. Is there still a role for you for THP? Or you feel like the default should be always T-DXd pertuzumab, but only in certain circumstances we should think about THP?
I always welcome options, and I never only have one option in my pocket. But from all the data, it's very clear that T-DXd plus pertuzumab should be the preferred first-line option. But one answer that I still don't have the answer yet, especially for those triple positive patients when they have indolent disease, and what I call is the HER2 addiction. That how much is a cancer addicted to the HER2, and the triple positive is hard for me to tell. So, if I have a patient with triple positive bone-only disease and grade 1 and really looks like more luminal type rather than HER2, I would be tempted and I would be having a conversation. And or, if the patients really had interstitial lung disease previously, and, when I'm anxious to give them T-DXd, I think that would be the only two population I can think of right now with the data.
Yeah. Paolo, I want to go back to you because you wrote one time an editorial about, did we say cure? And this editorial resonated with me so much. Nowadays, we can dream because of those drugs. We're seeing 15% complete responses. If you add the deep partial responses, you're getting to about 55% of the patients. Are we there yet? Can we dare say, like you said, you mentioned, can we dare say we are curing patients? And what do we need to do to show that in the future, yes, we are curing some of those patients, and who those patients are? That's one part of the question. The second part, will the Demeter answer that, or you're worried about that short time frame of T-DXd?
So I'm optimistic by nature, and so I do believe that we have enough data to really believe that for some patients we can eradicate their metastatic disease. It's not something biologically impossible because we see it with many cancers. We see it with lymphoma, with leukemia, with testicular cancer, with multiple types of cancer that with the right combinations we were able to eradicate the disease. And so I do believe we're already doing it with the CLEOPATRA regimen, and that we will increase the rate of patients cured with T-DXd pertuzumab. It's not the majority of patients. And so I think we need to think about these two aspects together, that we want to increase the rate, the tail of the curve, the cured patients, but also we don't want to overburden the rest of the patients that instead are treated with a palliative approach. So I think it's the magic of oncology, trying to balance these two aspects. One thing I believe is that 15% that we quote for complete response will grow. Because in DESTINY-Breast03, 21% of patients had complete responses. In the current analysis we saw at ASCO, we saw that the responses deepen over time. So with updates of the trial, I do think we will see more patients achieving complete responses, and we know that the complete responses are the most likely to lead to prolonged responses. So yes, I think we can dare to think that we're curing some patients. We cannot tell which ones they are yet, although we have some hints. We know that de novo patients are more likely to be cured, 3+ patients are more addicted to HER2, immunogenic tumors, PIK3CA wild-type tumors have more benign features. And I do think that will be an important consideration in a patient where you're considering THP. Because I totally agree that THP remains an option, especially for patients with de novo indolent triple positive disease. But I think the patient at the same time should be informed about the possibility that escalating treatment or utilizing a treatment for a prolonged time like T-DXd may potentially, we don't know yet, lead to higher chance of cure. And some patients may decide to go for a treatment that is longer in terms of cytotoxic treatment with T-DXd pertuzumab. Some other may want to do CLEOPATRA patina. I think this is the beauty of oncology, especially nowadays. We can really tailor approaches. But I do believe right now the rate of complete responses, deep partial responses we see in DB09 are unprecedented.
Yeah.
And so I think eventually this will lead to better long-term outcomes.
And to what Paolo mentioned, and something very interesting about this data that was just presented about the responders, is that the complete response and deep partial response, you would think about it should be the same in both arms, right? A complete response should be a complete response regardless of what they receive. That's not the case.
Yeah, it's quite interesting.
A complete response on the T-DXd pertuzumab is excellent. You look at the median progression-free survival, they showed us that the 2 years PFS rate, 85, close to 90%.
Yeah.
Deep partial response, 80%. Look at the THP arm. The complete responders, the 2 years PFS is close to 70%. If you look at the deep partial response, it's close to 60%. They're not the same. So thinking about all complete responders and all deep partial responders are being the same regard is not justified by that study. The treatment that they received matters how they got to that complete response.
100%. And I didn't answer on Demeter, but you read my mind even before I answered. Because I am a bit concerned that giving only 6 cycles may lead exactly to the point of the PFS curves where the curves start to open, actually open quite a bit. And that suggests that some tumors, in order to be kept from progressing, they do need exposure to cytotoxic. They do need that. And so the moment where you stop it and you just start HP, for instance, that's the moment where there's a higher risk of progression, which for HER2-positive breast cancer can mean brain metastasis, visual metastasis, organ failure. So I'm a bit concerned. I think there may be some patients for which it's enough because there is heterogeneity, but there will be some patients for which it's not enough. And so I do think the design of the trial that is starting to be designed, DB guide, that is gonna get closer to 1 year of T-DXd induction, probably is a bit safer. And I do look forward to seeing that trial open.
But Fengting, I want to go back to you. Like, not all CRs look the same. The treatment they got matters.
Yep.
Deep partial response matters. Does that challenge a little bit how we think about those complete responders?
Yeah, exactly. You know, that's the point I was trying to make. You know, what's the definition of complete response? You know, I was so mad that for leukemia, lymphoma, they have the MRD. And, you know, for breast cancer, of course, you know, all the studies are still ongoing. But, you know, even for the MRD, if you look at them, they are ultra sensitive and, you know, they are all different. So, you know, I think we need to relook at the definition of complete response, and perhaps that even there is no radiographic disease, there might be still some microscopic cancer somewhere that we did not eradicate. So, you know, I think by looking at that, I think, you know, we think the definition of complete response makes sense that for the T-DXd and pertuzumab group, perhaps because they were on the more potent regimen longer. So they literally had a true complete response rather than just a radiographic complete response.
Yeah, no, that's true. Paolo, I get to you because you mentioned the maintenance strategies. I mean, we got so many studies at the same time. We got the DB09, we got the Patina, and we got the HER2 CLEOPATRA. I mean, truly the DB09 came and ate everybody's lunch, I feel. Because those studies were so much in the making. Everybody was hyping them up, and then the DB09 came and took care of everything. Would you be willing to deploy those maintenance strategies in somebody who started on the DB09 regimen? Or because it was studied with THP, you will refrain from doing it?
So I find there's many strong opinions on this topic and wide heterogeneity of opinions, just like there's heterogeneity in breast cancers. I am on the side of those that feel a bit creative. If you have the option, why not? Especially for palbociclib. We know that it was only tested in a phase 3 trial in the first line. If you miss that opportunity, it's not that we use it in second line or third line. And also the data of Patina were outstanding. 44 months of median PFS. You want to use that option. And I keep thinking what could happen when you use in the best possible way the DB09 regimen and the Patina regimen together for these patients with triple positive disease. That sounds like the best of both worlds to me. So to me, yes, that we extrapolate all the time. When TDM1 was approved, it was not tested after pertuzumab, and still we used it after pertuzumab. Where Catherine was approved TDM1 adjuvant setting, most patients had not received pertuzumab, we use it anyway. Neratinib, we still use it in patients even after pertuzumab or TDM1. And so in this case, I think extrapolating a bit makes sense, especially for palbociclib. For tucatinib, it's a little more challenging because it was never proven that using it in the maintenance setting is better than waiting and giving it later. But especially in ER-negative disease, these patients have a high risk of brain metastasis. I think it's not unreasonable. But particularly for Patina, I'm compelled to consider that. But I hear the purists that prefer just using one approach. And I think it's the way it's supposed to be, some heterogeneity of opinions.
I think this is an important question, so I want to hear your opinion on that.
Oh, absolutely. Especially when I had the patient in front of me, why do I want to wait until the disease progression and give them regimen chemotherapy cause alopecia and with potentially similar PFS? So a lot of the patients I'm treating that, you know, if we can, how I look at that is if we can keep the disease at bay rather than treat them later with progression. And I think it makes a lot of sense to me that, yeah, I understand the Patina was in a different setting, but I absolutely would be open. Let's say I have toxicity, and when I had to discontinue T-DXd and pertuzumab, I would want to make sure I have a discussion, and if the patient is open to it, and I don't see any reason we cannot use that.
Fantastic. So now I want to end on two things, one for Paolo and one for you, Fengting. First with Paolo, because the community oncologist is going to say now, all right, great, you're going to make me use T-DXd in first line, what I'm going to use after? But also they're going to be thinking about, well, now you're bringing T-DXd to the early setting, what I'm going to do when the patient becomes metastatic. So I'm going to start with you, Paolo, in the early setting. Now that T-DXd is moving to the neoadjuvant setting, to the adjuvant setting, if patient reoccur, is the DB09 regimen still valid?
So I thought a lot about this. I think we have no perfect answers, but I think we can kind of recycle the standard approaches we've been using with other drugs, like taxanes. So I do feel if you have at least 6 to 12 months of treatment-free interval, it makes sense to utilize the same drug if you know it's so effective. And I think this is valid both after adjuvant T-DXd, but also in the metastatic setting. If the patient has been on a maintenance approach for 1 year or longer, I think it makes sense to re-challenge with T-DXd. It is different if a patient has a recurrence or progression while on T-DXd. And there we have many options, none of which is totally standard. And my preferred approach would be to basically swap the order and use taxanes. I love taxanes. I think they're very effective, but other approaches would not be wrong, and I would love to hear.
Yes. So Fengting, for you, so now let's talk to our community oncologist, the doctor who used to say, okay, you convinced me. I'm not going to keep it in my back pocket. I'm going to use it up front, but we are still not curing a lot of our first-line patient that eventually going to need a second-line plus. How do you navigate that? What would you give them after progressing?
First of all, I want to reassure everyone that it's not often. When you look at the DB05, DB11, I'm confident that we are curing more than 90% of the patients, so it's not going to be a lot of patients. I typically, when the disease progress on T-DXd or in shorter than 12 months, I would reach out to other regimen. And we still have THP, we still have tucatinib regimen, and we still have TDM1. We still have a lot of other chemotherapy plus pertuzumab and trastuzumab, Perjeta. We still have quite some options in our back pockets. But if the cancer reoccurred more than 12 months after completion of adjuvant T-DXd, I would be very comfortable to re-challenge. It is more like the stage 4 setting, when I had to give them a break from the treatment, but when I would be comfortable to re-challenge later if the side effects were acceptable. So the good news is this is such a fast evolving field that I'm not too worried, and I'm confident that we have so many clinical trials going on, and I always want to put them in a clinical trial, and we will have newer agent coming out later.
Paolo, just back to you, because I truly meant in the metastatic setting, right? The patient we're not curing a lot of them. You mentioned one time to me that you can still recycle or use other antibody-drug conjugate after T-DXd. Can you tell us about that a little bit?
Yeah, I think it's fascinating because there's kind of this thought that HER2 ADCs cannot work one after the other. But actually, the data proves the opposite because DESTINY-Breast03, randomized trial of T-DXd versus TDM1, T-DXd had a PFS 4 times the one of TDM1, 29 months compared to about 7 months with TDM1. But then they looked at the outcomes of TDM1 given after T-DXd, and serendipitously, I was lucky to be presenting a poster in front of Peter Fasching that was presenting this data. And I looked at it, I was like, whoa, that's impressive, because TDM1 seemed to fare better when given after T-DXd. It had over 7 months PFS, and that I think suggests that when you use T-DXd early, you debulk the disease. Once it progresses, it may progress from a place that is better than where it was at the beginning. And so actually TDM1, that is as a different payload, a microtubule inhibitor, may work well. And so I think we should keep it up our sleeve and utilize it when needed. It's still a great drug. I do love ADCs, each one of them, especially the first one developed for breast cancer.
Yes. And last question, Dr. Fengting. Is there a role for THP after progression on first line T-DXd pertuzumab, or you will just go to a tucatinib-based regimen?
That's a great question. I don't think we know that. It would be more a discussion that do I truly want, depending on how fast it progressed and depending on the disease, and truly I think it's an option in the pocket.
Yeah. Well, Thank you so much for joining us, our audience. I mean, I enjoyed it so much. I hope you enjoyed it too. Don't forget to be on the lookout for more exciting program from Community Health Media. Until next time, thank you so much.
Thank you so much.
Thank you.
Thank you.